So you've heard some great stuff, haven't you? You've heard cutting-edge continuous GFR monitoring. Niche is going to cure the Alberta of contrast-induced nephropathy, and space-age stuff for your cardiac surgery. So now we've got me making some stuff up, so we'll see how we get on. So Claudio's not only given me the last talk, but I've got minus 1 minute to do it in, and we're going to talk about integrating new technologies. It's interesting how he picked the term a cost-constrained health economy. There's my disclosures, which some of you may have seen an hour ago. Right, and I'd like to thank Claudio as ever. And also Fiorenzo Ferrari, one of his ex-research workers, who's just lent me a few slides. This is what a lot of us feel in England, and probably some of you feel in Europe, that Brexit really does suck, and some of us were deeply disappointed at the results of 23rd of June. But clearly, it's beginning, this mentality is beginning to seep into Italy, because I did notice yesterday that there was this poster of Italians only, so perhaps we're going into a completely fragmented Europe, which Claudio has triggered. He's going to kill me for this, I'm sure, but that's but Brexit does suck. So how do we integrate new technologies, and especially in our beloved NHS, given that the NHS is in a critical state? More of us are on prescription pills, docs warned of care time bomb, A&E swamped, we're in a crisis budget deficit. And it's not just a one paper, you can see there's a whole collection of here. Hospitals can't cope, NHS hits breaking point. Is it all about money? Well, I think probably it is really. I mean, this is a graph showing the difference between real spending, a percentage of the national income, which is produced by the government, which you can see cuts off about 2014. We do have something like called the King's Fund, which is a watchdog, really, that looks over healthcare. And you can see they're highlighting there that we're currently undergoing the largest ever sustained reduction in UK NHS spending as a percentage of GDP. And not only that, our GDP is falling. But it's not just in the UK, as Dr. Ferrari gave me. This is the forecast of the Italian GNP and public debt ratio, undergoing different scenarios. Graphs like this that go down are not bad news, really. And this was the other thing she showed us in terms of percentage for the public healthcare budget, which is about the same as the UK, around about 7%. So there's going to be less money. And the problem is when we're trying to innovate and bring in new technologies, it's difficult. And within our institutions, there are several barriers to that. And this is a great article, actually. The one thing I will thank Claudio for is he made me go off and read stuff I don't normally read. And this was a particularly interesting article, talking about why innovation in healthcare is so hard. And I would urge you to have a look at it. It's good bedtime, really, if nothing else. And these are 6 forces that they highlight that can drive innovation or kill it. And you can imagine, just looking at the players, right? Your friends are all for your new technology, and your enemies, namely the surgeons, present company accepted, of course, are against your new technology. Funding, the way we acquire capital and the way we're funded is different. Policy, that drives a lot of it. If the policy change, healthcare policy changes throughout the institution or the country, then it's difficult. Technology, the customers, what the customers want. And it makes a very valid point that the increasingly engaged consumers of healthcare, which they are, the Google mum who comes in to see you in the outpatients who's printed everything off. Yeah, the passive term patient, as they outline, seems outdated. So they really are customers. And accountability from both consumers and paymasters. So if we're going to try and introduce a new technology, what are we striving for? Well, we're striving for a cost-benefit balance, really, or as the economists prefer to view it, as cost v value. And this is actually quite an important concept, really. If you're paying X amount, what are you getting for it? And we apply that outside of work all the time. What are you getting for your value for money? So you might want to buy a particularly economical car because that suits your budget, or you might want to blow it all on a Porsche, but you have to balance that up yourself. And yet when it comes to applying that to our healthcare systems, certainly in the UK, people kind of lose grip of reality, really. So bang to the buck or bounce to the ounce, whatever you prefer, how do we actually quantify it? And how do we work out which technology is going to be cost effective and how can we implement it? Well, this is a whole industry now, and my American colleagues are probably thinking I'm somewhat retarded talking about this. But in fact, for us, it's a relatively new thing. And this is from a paper called Cost-Efficient Resource Allocation, a journal called Cost-Effectiveness of Resource Allocation, which is an interesting, if not somewhat challenging read. So this is a paper talking about international lessons in methods for grading and integrating cost effectiveness, particularly into clinical practice guidelines. So when we write our practice guidelines and perhaps think about introducing a new technology in that, there are well-briefed methods now that you can work out if things are cost-effective or not. The interesting thing about some of these journals is we get criticised, certainly at home, I don't, but some people do get criticised about the fact we use a different language that the patients or customers can't understand. Well, certainly there are parts of this journal that left me somewhat bewildered. So you can see here, COAG, AHMAC, IHPA, and something else, and the Australian Department of blah, 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 blah. So it really is, as I said, quite challenging. So you're forever looking back at what these acronyms stand for. Most first world, shall we say, health economies now have economic evidence integrated into any form of health technology assessment. So if you're trying to get something adopted, you've really got to play the game, really. And as I said, clinical practice guidelines, if you introduce a new technology within that, enables ready economic evaluation. And that includes systematic review, which is probably worthwhile getting one of your fellows to do first. Decision rules are part of your clinical prediction algorithms, opportunity costs, and of course what it'll add in terms of social value. And these things called cost effectiveness analysis thresholds, which to my reading looks a bit like the son of QALY. So it's another way, or a way in which cost effectiveness can be discussed. And of course, this paper highlights some of the health technology assessment agencies throughout the world that apply this technology. And one of these is one that's beloved to me, which is NICE, which can be one of these three things. It can be a coconut biscuit, a nice place in the south of France, or the National Institute for Health and Clinical Excellence. And they are our independent watchdog, which allow for health technology assessment. Now, what is it? It was established in 1999 as a special health authority, and it has developed now into a watchdog that's completely independent of the NHS. What does it do? Well, it does lots of things, but the main thing is it publishes guidelines in 4 areas. One of those is the use of health technologies. So in the UK, at least, if we get NICE approval, then it's fine. We have carte blanche. We're allowed to use the technology. If we don't, then we're off-piste and we don't get paid for it. So it's actually quite useful in some ways, but I think in some ways a drawback to innovation because it's based primarily on evaluations of efficacy and cost effectiveness. So you can't go to NICE with a plea to do some research because they'll say, well, no, you've got to do all that before you come and see us. And unfortunately, it also plays an important role in other healthcare systems now. And there's something called NICE International. And that was established in May 2008 and works with other governments. And here we are, NICE International's brochure. And as I said, it's not just in the UK. And these are the kind of basic tenets of NICE International, but certainly one of the key factors is to ensure value for money by setting up evidence-informed national purchasing and reimbursement processes. I won't bore you with the platitudes about NICE. And the appraisal guidance can be related to any of these things, so medical devices, diagnostic techniques, etc. So if you're going to ask me how you would implement changes locally, it's difficult for me to talk about what happens in Germany or Switzerland. But this is an interesting paper. I'm not going to go into it, you'll be pleased to know. But it's talking about integration of a new technology in the ED. And what this paper quite clearly shows is one of the best ways to introduce it is to have a full multidisciplinary team involved. So if you've got evidence and a full MDT, and lots of partners that support the technology, then you're probably in the box seat and you're going in the right direction. The problem is there are lots of confounders, particularly with new technologies. There's the budget holders, the cost-free value, as I told you. Who actually accrues the benefit? And I'll give you an example of that in a minute. And then you've got fee-for-service contracts and people being tied to a single technology, particularly in cardiology and surgery. So that's always a difficulty. So here's an example that if you imagine introducing a new biomarker into the ICU, okay, who pays for it and who gets the benefit? So if we do it in cardiology patients, do we expect them to pay for it? Or is it our ICU budget? Similarly, nephrology. Do they pay for it, or does the intensive care, surgery, or the ED? So lots of people may accrue benefit, but not many of them are queuing up to pay. So you have to try and think within your institution how you're going to actually rationalise where you're going to sit it and who your partners are going to be. And so whenever I've tried to do it, I'm in the process now of trying to put in these cell cycle arrest biomarkers. How do I do it? I think tying it in with some form of quality improvement process is absolutely essential. Absolutely essential. Because if you can show process change and maybe not improved outcomes, but perhaps improved length of stay, for example, you'll have a very strong footing. And also, if you do this, it allows effective audit and economic analysis. Unfortunately, you're going to have to be prepared to fail occasionally. But I suppose that's part of fun of the job, isn't it, really? So if you are going to try to introduce some new technologies, I'll keep my fingers crossed for you. And with that, I'd like to thank you for your attention, and particularly to thank Claudio for yet another fantastic meeting. And I can't wait for number 36. Many thanks.